Welcome to this presentation of new interRAI research, published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson from Doctors Manitoba, and I'll be moderating today's session. The presentation today will include two interRAI fellows who collaborated on a paper entitled Mood Disturbances Across the Continuum of Care, based on self-report and clinical rated measures in the interRAI suite of assessment instruments. We will begin with a brief presentation by Dr. John Hirdes. John is a professor in the School of Public Health Sciences at the University of Waterloo and the Senior Country Fellow for interRAI in Canada. He serves on the interRAI Board of Directors and is chair of the interRAI Network for Mental Health. John will be joined by Dr. Margaret Saari. Margaret holds a doctorate in nursing and is a researcher at SE Research Centre in Toronto. She is also appointed as an adjunct professor at the University of Toronto's Faculty of Nursing. We will provide a web link to the articles in the special issue at the end of today's webinar. John, over to you.
Thank you, Keir. It's great to have the opportunity to present today on a new outcome measurement to be used as part of the interRAI family of assessment systems. Mood disturbances are important to think about because in many ways they can be a universal human experience. We can see issues related to disturbed mood in geriatric settings, in child-youth settings, in mental health settings for adults of all ages. And the interRAI family of assessment instruments is uniquely designed to address common issues like mood disturbance across care settings. And so that's the point of the paper that we've just recently published in Frontiers in Psychiatry, and that Margaret and I are delighted to have the opportunity to tell you about. So our research to develop a new mood scale was focused on creating a successor scale to the depression rating scale. The DRS is very widely used across different care settings, but it does have some important limitations that have been noted over time. So for example, it does not include items related to anhedonia, which is an important part of depressive symptoms. And we've also noted that clinical ratings provided by clinicians can sometimes differ from the results you obtain from self-reported tools. So it's important to reconcile those differences. Our focus in this research was on the identification of mood disturbances. So we're not trying to create a diagnostic scale that leads to a definitive diagnosis of depression, for example, because changes in mood could be both ongoing problems related to depression, or they could be transitional states that change rather rapidly over time. So our focus is on the current manifestation of signs of mood disturbance. And our aim with this research was to create a single compatible approach to measurement that would work across different care settings and different populations. Now, this table will be a little bit small to see. It comes directly from the paper, but it describes the populations that we saw and the settings that we worked in. So our research was based on all Canadian data from community mental health agencies, from home care agencies, from community support service agencies, from primary care settings, long-term care settings, palliative care, emergency departments, and two general community surveys prior to the pandemic and one during the pandemic. Some of these populations serve mainly older adults, some target adults of all ages, and the community samples target everybody in the general community. All told, we used 500,000 interRAI assessments from 9 different clinical settings in order to do this research. So we ended up creating 3 variants of scales that deal with mood disturbance. The first variant is a clinician-rated only scale that uses 4 clinician-rated items. The reason that we created this is to allow for backward compatibility with legacy instruments like the RAI Home Care, the RAI Mental Health, and the MDS 2.0. Our focus for this paper, though, was primarily on the new self-rated and composite mood scales. So the self-rated scale uses 3 items related to dysphoria, anxiety, and anhedonia, and they can be added up to create a single summary score. We can use these in survey research or in self-report tools that can be used in clinical settings like in primary care, for example. The composite mood scale is a 7-item scale that uses 4 clinician-rated items and 3 self-report items into a single combined scale, where we first start with the person's self-reported ratings on those 3 domains of dysphoria, anxiety, and anhedonia. But we substitute with the clinician rating if the self-report is missing, if the person did not or could not or would not respond, or if the clinician rating is higher, indicating more severity than the self-report. So the composite mood scale provides a more sensitive, higher score, whereas the self-reported mood scale is focused on the person's perceptions only. All 3 of these scales have scores that range between 0 to 9, where 0 indicates that no indicators are present, and 9 indicates the worst state of mood disturbance. As part of this paper, we did quite a bit of work on psychometric testing. Previously, we've done research within interRAI to demonstrate the inter-rater reliability of the items that are used in the creation of these scales. So we did not repeat that here because previous work dealt with that issue. What we did in this paper was to assess the internal consistency of the scales using the Cronbach's alpha score. And across all of these settings with these various scales, we got good to excellent ratings of Cronbach's alpha values in each of those clinical settings. We also did different types of research related to validity. On the content validity side, our focus was really ensuring that we included the 3 dimensions of depressive symptoms and anxiety in the scale to ensure that that was more fully represented than was true in the DRS. We also focused on convergent validity to see was the scale score associated with a diagnosis of a mood disorder or depression. Was it related to sleep disturbance as a clinical sign that's often commonly associated with mood disturbance? And was it related to self-harm behaviors and ideation? We used that for creating cut points in the scales. We also did work on criterion validity, comparing it with the Kessler-10 psychological distress scale, because the Kessler-10 is very widely used in survey research. It can be considered a gold standard measure for psychological distress in community surveys, so it was important to establish our validity in relation to that. Our future work will focus on doing predictive validity research to see, does this predict new diagnosis of depressed mood, for example, in the future, or self-harm related behavior in the future. So the result was we were able to describe the distribution of mood disturbances in these different clinical settings with both the self-report and the composite version of the mood scales. In these graphs, the green part reflects the persons who had no indications of mood disturbance, and the red part shows people who had severe distress or disturbance based on those cut points using self-harm related indications. So not surprisingly, the highest rates of the most severe scores on the mood scale were in the community mental health settings on the far left, and the lowest ratings were in the self-reported community sample done prior to the pandemic. One of the surprises of our research, though, was that when we did the online community survey of the general population during the COVID-19 pandemic, we found rates of mood disturbance that were almost as high as we saw in clinical mental health settings in community mental health services. And we've actually published a separate paper in the Frontiers of Psychiatry issue dealing specifically with mood disturbance in the general population during the pandemic. This shows the validity work that we did against the Kessler-10 scale with the community sample. The horizontal line at the Kessler score of 30 reflects the recommended cut point for severe psychological distress according to the Kessler-10. And so what I see in this graph are a couple things. One is there's a clear, strong relationship where higher scores in the Kessler-10 are associated with higher scores on the self-reported mood scale. And the other thing that's interesting is our cut point of 6 or 7 on the self-reported mood scale corresponds quite well with the recommended cut point of 30 on the Kessler-10 scale for severe distress. And then the correlation between the two measures at 0.73 is very strong. So the key takeaway points from our research is that we now have a new scale that allows us to address mood disturbance in a common methodology across a broad range of clinical settings and a broad range of populations. interRAI is recommending in the future that this be used as an alternative to the DRS. It does address many of the criticisms and limitations of the DRS that have been reported in the literature. For those who wish to use the DRS, it's still available for all the older instruments, but we will be discontinuing it in the future versions of the interRAI instruments in favor of these new mood scales. We will be able to do backward compatibility testing with the clinician-rated mood scale from those newer instruments to the legacy instruments. Our future research that we're going to pursue will be international replication of the validity and reliability testing of this work. We'll be evaluating the predictive validity of the scale for diagnosis and self-harm behavior. We'll be testing it in new populations that we haven't tested yet, including adults with intellectual disabilities and children and youth. And we'll be working on development of quality indicators and applying these new mood measures in case mix systems across different service settings. So thanks for the opportunity to present this new work to you.
Thank you very much, John. I appreciate the presentation. And of course, interRAI has a very long tradition of research related to mental health outcomes in clinical settings. And I wonder how this new research enhances the usefulness of interRAI systems with respect to mental health.
Well, this is an example of interRAI's commitment to doing ongoing research to keep making our instruments better. So when the DRS was created in 1999, it was an important breakthrough because it provided a major standardized way to measure depressive symptoms in a consistent way across different service settings. And so as a co-author of that work, I can say the DRS paper is one of my most highly cited papers. It clearly had a substantial impact in the literature. But we also learned about some of the limitations of the DRS that I mentioned, that there's some domains not well represented, and you had this interesting phenomenon that self-reported measures like the geriatric depression scale would give different answers than the clinician-only rated DRS. And so we learned from our own research, and we responded to feedback in the scientific literature to develop this new scale. But we also wanted to fill an important gap because the DRS could not be used in a lot of community settings. So for example, you can't do a national survey to have nurses online to ask questions as part of a survey research effort. And in many low resource nations, there's not enough health human resources available to do broad-based screening. So adding a self-report tool into the mix suddenly expands our applicability to primary care, community-based research, and outreach programs with non-health professionals.
So I noticed in the presentation that you incorporated a number of different settings into this research, which is quite interesting. And I wonder if you could tell us a little more about why it's important to think about mental health across different care settings.
Well, the key consideration here is that mental health problems don't just occur in psychiatric settings. Mental health issues are common in human populations of all ages and all types. So there are people who experience depressed mood or distressed mood in inpatient psychiatry and community mental health settings, but it's also true in home care settings, in nursing home settings, in palliative care settings, in primary care. Mood disturbance can be one of the fundamental characteristics of the human condition. Just like pain is an experience that affects people of all ages, clinical symptoms like gastrointestinal symptoms can affect anybody anywhere. And so we can't just create instruments that work only in one setting. We need a common way to measure mood for people wherever they're receiving services in the health setting.
Thanks. And of course, you talked about the 3 different variations of the mood disturbance scale, and you touched on that a little bit earlier. I wonder if you could tell us a little more about why interRAI created these 3 different variations.
Yeah, so the 2 novel measures that come from this research are the self-reported mood scale and then the composite mood scale. So the self-reported mood scale was to give us that flexibility to reach into populations where a clinician is not available. So it could be in community-based survey research or surveys that are being done as part of program evaluation is one place where you'd use a self-reported mood scale. In primary care, most physicians have under 10 minutes to do a primary care visit. And so the idea of having a self-reported mood scale that could be filled out by the patient in the waiting room independently has a lot of appeal. In the mental health literature, there's an interest in something called measurement-based care, where self-report tools can be used to track outcomes over time. So this fills an important gap that way as well. And then, as I mentioned, in low-resource nations where there's not a lot of clinical staff available, we can use tools like this with lay health visitors to get information on mood disturbance in those populations. The composite mood scale is important because of some of the limitations of self-report measures. So one limitation of self-report measure is you have to be able to self-report. So if you have cognitive impairment, like you see in a palliative care population for people that are close to the end of life, where they may have fluctuating states of consciousness, or in a long-term care setting where cognitive impairment is pervasive, we need to have a mechanism for tracking mood disturbance that is not based on the self-report for those who are unable to respond. So that's where clinician ratings can be used as a substitute. And the other issue is, what do you do when you have competing information where a person provides a self-report that may underestimate the severity of their experience, and the clinician has clear confirmatory evidence that the problem is more present. So for example, here, if you're interviewing me and I'm tearful and clearly distressed, and you ask me, have I felt sad and depressed in the last 3 days? And I say, no, I'm fine. Then you've got a dilemma. Do you believe my self-report only, or do you use your own observations where you're pretty convinced that something's going on? That is where the composite mood scale allows us to use the more severe clinician ratings to get the most sensitivity to potential mood disturbance.
And so when it comes to clinical depression and mood problems, can you tell us a little more about what the difference between those two would be?
Yeah, so as I said in the presentation, the new mood scales are not diagnostic scales. So they're not ones that at the end can confirm a diagnosis of depression, for example. So depression tends to be characterized by a more persistent, ongoing disturbance of mood that may last over a long period of time and may be resistant to change in social circumstances, for example. Whereas mood can be a transitional state that may last for a few days. So people who have mood disturbance may be upset for a few days and may recover from that, or they may have mood disturbance that's part of depression that's ongoing. So there's likely to be an association between mood disturbance and depressive symptoms, as we found in our paper, but in some cases that disturbed mood state is a transitional short-term state, but it's still really important. Nobody wants to be upset even for 3 days.
Great. And just before I bring your colleague, Margaret Saari, into the discussion, I have one more question for you. What do you see as the implications of having this new mood scale for the depression rating scale?
Well, this adds another tool in the toolbox for clinicians to use. If they want to use the DRS, they can continue to do so. It has a consistency with it in the sense that higher scores on the mood scale will also be associated with higher DRS scores. But for those who want some more refined tools to deal with mood disturbance, this is definitely an enhancement over the previous instrument. Now, you will, for the older instruments like the RAI Mental Health, the RAI Home Care, and the MDS 2.0, you'll still have to use the DRS because the self-reported mood items are not available there. So you can only use the new mood scales with the new suite of interRAI instruments, and that's an important reason to make that transition.
Thanks. So let's bring Margaret into the discussion. Margaret, of course, was a collaborator on this research. And I wonder if you can help us understand a little more about why mood disturbances are important to consider as an outcome variable in healthcare.
Thanks, Kier. So first, and I feel most importantly, mood disturbance is important to include as an outcome variable purely due to the profound impact it has on an individual's personal well-being and quality of life. So including that measure that assesses kind of that management of mood disturbances as an outcome when evaluating quality of health services, we really emphasize that caring for the whole person is something that we place value on. So it aligns with that broadened definition of health, one that reflects a person's physical, emotional, and functional well-being, and not just the absence of disease. And of course, from a system perspective, it's also important to consider mood disturbance because of the known impacts on a person's engagement with their care team, their ability to recognize symptoms and manage their chronic health conditions, as well as their adherence to treatment plans. So failures in this area have important and costly health system impacts, including increased health service use and elevated resource intensity.
So maybe we can delve a little deeper into that. How can problems with mood affect compliance and treatment approaches for other conditions?
Yeah, so common symptoms associated with mood disturbance can really impact somebody's ability to effectively manage their other health conditions. For example, I'm going to give some examples here. For someone living with depression, the reduced energy or their lack of interest in cooking could result in a nutritionally poor diet, impacting their ability to manage their diabetes effectively. So that's one example. Or another might be that a person could have sleep disturbance, which results in some excessive sleeping and then poor adherence to their prescribed heart failure medications, leading to an exacerbation of their symptoms and maybe additional ED visits. So this is really a key reason why we need to have a clear understanding of the impact of their mood disturbances on a person's day-to-day functioning and be able to create that plan of care that identifies these potential issues and creates a plan to manage them effectively.
So recognizing the importance of that, I imagine for clinicians and others involved, these things don't always present the same. And I wonder if you could talk about maybe how cultural factors affect how mood disturbances are expressed and approaches that should be used in providing mental health services.
It's a really great point. So culture affects the way that we express our thoughts, our behaviors, our emotions. And so it's therefore not really surprising that cultural differences impact the way that our mood disturbances are expressed. So one of the main differences seen across cultures is the way that anxiety and depression is expressed. Someone from a culture where it's common to know psychological terms may be able to easily describe their symptoms using those specific words. But in another culture, other words or language may be more common. And so you actually have to dig a little bit deeper to understand exactly what somebody is feeling or expressing. Additionally, for some cultural groups, expressions of mood disturbance might not be considered socially acceptable, and that could result in denial or underreporting of symptoms and individuals not seeking treatment. So it's really critical to ensure that we're using that person-centered approach to care, using language that is understandable to the person to be able to build that trust, and that we take these differences into account, both when assessing for mood disturbance, but also really when building that treatment plan. So who do you bring in? Who do you talk to? Is it okay to talk to a certain family member, or do you need to talk directly to that individual? Those are all considerations that need to be taken into account when building out those treatment plans.
Thanks. So what can nurses and other healthcare professionals do to prevent problems related to mood in healthcare settings?
I think prevent is hard, but I think we really need to start by including that assessment of mood in day-to-day care across all care settings. And as John talked about before, and assessing mood from the from the perspective of the person. Therefore, any healthcare professional can really start a conversation about how mood is impacting their well-being. And from there, that care plan can be built with the client, which meets their preferences and their needs. This can lead to earlier targeted intervention, which maybe could identify and link people with appropriate services to address mood issues. And it could help to prevent transition to more severe mood disorders, as John talked about, from that transient state to something that's more persistent. I think also asking about mental health and mood contributes to that normalization of mental health as a critical component of overall health and well-being. It's important that we recognize and account for the critical role that mood disturbance can play when developing our care and treatment plans, as I've already said, and really working with the family and the person to mitigate the impact of those mood-related symptoms on their treatment for other conditions to really set those clients up for success.
Great. So maybe I'll bring John back into the discussion now. Of course, we're hoping we're at the tail end of the COVID-19 pandemic, and there's been so much said and so much research done around how the pandemic has affected people's mental and physical health and well-being. So I wonder, in your research, how did the pandemic affect the mood of the general population and in the clinical settings that you looked at?
It's really been quite remarkable to see the impact of the pandemic on mood disturbance in the general population. It was an enormous increase in mood disturbance that we saw. We've reported it in this paper in Frontiers in Psychiatry, as well as a second paper led by Gustavo Betini. And the thing about it is the mood disturbance persisted over the various waves of the pandemic. In some sense, you might think about, well, the first wave of the pandemic is when we had this sort of sense of loss of understanding of how the world was working. Emil Durkheim talked about a sense of anomie, of a loss of norms, and the stress that can lead to mental health of general populations. He did that work in the 1800s. And we certainly saw a good deal of that in the first wave. But one might have thought that afterward, things might settle down as people got a sense of how this was all working and how to deal with it. But in fact, the mood disturbance in the general population was quite persistent over time. And perhaps it's because the other kind of consequences, the economic considerations, the social upheaval, and the sheer fatigue of just wanting to be done with this thing and get on with our lives manifested itself very clearly in the mood of the general population.
And Margaret, did you want to add your perspective to that?
Sure. I'll talk a little bit about clinical settings. So obviously, related to that increase in the general population, you do see an increase in the need for our clinicians to be addressing those mood issues, adding to the general workload of individuals and the complexity really of caring for individuals during the pandemic. On top of that, you have the restrictions that were placed on clinicians in terms of, visiting individuals, having to do video calls and teleconferencing for their clinical visits. And it's just kind of building and building. On top of that, they're also people on their day-to-day. So they also have the additional stresses that John already talked about. So what we're really seeing in that clinical setting is kind of, I don't want to say a burnout, but it is that multiple levels of stress and distress. Then add on top of that piece, the staffing crisis that did occur due to a number of different pieces, staff being off, nurses having to work in different positions, such as, moving to the vaccine front. It just led to less staff to do more work. And so really the mood in the clinical setting is one of distress, and we are seeing that impact now in predicted mass retirements of nursing to be coming over the next kind of couple of years.
Yeah, certainly here in Manitoba, I'm with Doctors Manitoba, and our survey of physicians here has found high levels of burnout, moral distress, and 2 in 5 over the next 3 years thinking about retiring or reducing their hours or getting out of medicine. So it's quite distressing for everybody, but for the clinicians working through this pandemic, of course, it's been very difficult. John, I wanted to circle back to something you said near the beginning, and it's certainly something I've come to know of interRAI, which is that the work's never done. As good as a scale is, you're always looking for ways to make it better. And today's presentation and discussion has been really interesting, but I wonder what's next for research in this area, in your opinion?
Yeah, so this paper took a while to do, in part because I wanted to really cover all of these clinical care settings at once. I wanted to be able to show that we have a mood scale or a set of mood scales that can work across all the major sectors of the health system and multiple populations. And Canada is one of the countries where we have the most broad-based implementation across different sectors. So part of it was waiting for getting all those data together to give this great pan-sector view of the health system. That means that this paper had a focus on Canadian data, but not international data. within interRAI, we have at least 35 other countries involved in the interRAI research network. So the next obvious step is to do the cross-national validation in different countries, different health systems, different cultural populations, to be sure that they're replicating the findings of the Canadian work. And they can do that piece by piece. They don't have to do the whole suite research like we've done here to demonstrate that. But for example, in New Zealand, there's broad-based use of our long-term care and home care instruments. In Switzerland, they've just implemented our community mental health instrument. So we'll be able to do validation in those different countries as well. But I'm also very excited about a new project that we're doing in Africa called the PAULUS project, the Pan-African Utilization of Lay Assessment Systems, where we'll be using lay health visitors in 10 African nations to use the interRAI checkup instrument in primary care settings to evaluate the needs of older adults in those 10 different countries. That checkup instrument includes the self-reported mood scale. So we're about to launch a major multinational trial in a low resource part of the world to explore the feasibility of using this for broad-based screening of mental health in vulnerable populations in those settings. So we're very excited about that as our next step of research.
Okay, that was 60 seconds, and it sounds like there's a lot of potential here. So Margaret, I wonder if you want to have the last word on what you think is coming next.
I think also I'm really interested in moving forward with implementation of this scale to see how it impacts some of the care that we are providing in a number of populations. One that I'm really very excited about is the transitional care population, where we have individuals with a lot of mental health needs that maybe aren't being addressed as well in the home and community setting. So hoping to be able to see a difference in the ability to use the self-report component of the tool to improve the care plans we have for those individuals and making sure that we're really setting them up for a good transition back to community.
Well, thank you both, Dr. John Hirdes and Dr. Margaret Saari, for joining us today and for your very interesting work on this clearly important topic. We look forward to hearing about the future developments of this important work. Thank you for watching this presentation of interRAI's research in mental health and addictions. If you would like more information about this or related work, please contact us at info@interrai.org. That's info@interrai.org.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at any time to view new presentations on this special issue as they are posted.